Thank you, Bala, for the very kind introduction. Good morning, ladies and gentlemen. Namaskar, vanakkam. So I've been given the task to try and decipher what these various terminologies really mean when it comes to peripheral nerve blockade, and to try and define if these terms really make a difference. I have no conflict of interest. As I mentioned, I'm the editor of 2 recent textbooks, but it's not going to influence what I'm going to be saying today. But many of you have been asking me how they could get hold of one of this. I think there are a few pamphlets lying in the main registration desk, right in the center of the hall. And you can pick up one of those leaflets and it'll tell you exactly what you should be doing. Okay, I also take this opportunity, since this is the last time I'm going to be upstage, is to invite you to this meeting that I hold every year. It is a festival of advanced regional anesthesia for pain medicine, for anesthesia, for musculoskeletal. So it sort of, it provides for a host of different specialties. The date's also very interesting. As you can see, it's from the 20th, it's on the, if you arrive in Hong Kong on the 20th of February 2020, you'll be perfectly set. Now, I think in order to understand these terminologies, we need to understand the functional anatomy of a nerve. Unfortunately, when it comes to the functional anatomy of the nerve, what's described in many textbooks is a very simplistic presentation. For this discussion, I'm going to use the sciatic nerve as my template because it's a large nerve and it's easier to understand. This may apply to most peripheral nerves around the body. When you look at the peripheral nerve, it's most textbooks, this is the picture you often see. They say there is an epineurium, which is the outer layer, outer epineurium. Then you have a perineurium, and then you have an endoneurium, which basically covers each of the individual nerve fibers. So, is it so simple? Because today we are getting closer to the nerves, and I think looking at the nerve in entirety is more important. Now, the other thing that we often need to understand is the pharmacokinetics and the dynamics of the local anesthetic during any plexus block. This is a work done by Professor Winnie many moons ago in 1997, and I think it very much applies today, and many of you in this audience may still be aware of it. When you look at the peripheral nerve, you have a mental nerve fibers and a core nerve fibers. Of course, there are vascularity within these nerve fibers. So the mental are the peripheral part of the nerve bundles that are around the outer part of the nerve. As you see here, this blue represents the mantle fibers and these core fibers are in the center. What happens when you inject a local anesthetic? Professor Winnie showed that, and they actually did it very painstakingly. They injected the local anesthetic, they measured the sensory motor changes from a proximal to the distal part of the limb after a perivascular supraclavicular brachial plexus block. As you inject the local anesthetic, the drug diffuses against a concentration gradient, so it enters the mantle fibers first. So as a result, the concentration of the drug first reaches the CP max, or the optimal concentration, the ED95 in the mantle fibers. So therefore you get blockade of the mantle fibers first before the core fibers. Thereafter the drug would diffuse further into the core fibers, and the core fibers actually supply the distal part of the limb. So the mantle fibers supply the proximal part and the core fibers supply the distal part. And then an phase of equilibrium occurs where the nerve's sensory motor blockade is complete. Thereafter, there is a washout of the local anesthetic from the core to the periphery. So recovery occurs in the reverse direction, and thereby the concentration first drops in the core fibers and thereafter in the mantle fibers until complete recovery. So, if we look at the first anatomical picture I showed you and you put this into perspective, that is how nerve blockade is usually described, and most people usually understand this, so that there is a extraneural diffusion time and there is an intraneural diffusion, both ingress and egress of the drug, and this constitutes the total onset time or the offset time of the block. But I believe, and I submit to you, ladies and gentlemen, that when you look at a nerve block, I think we should look at it in entirety, because there are many structures that surround the nerve that can influence neural blockade. What I have presented so far surely does affect the onset and recovery of the drug, but I think understanding the functional anatomy in more entirety is important. Now, this is a work we did many years ago, looking at the three-dimensional image of the sciatic nerve in this proximal part. You can see here the sciatic nerve lies deep to the, Okay, the sciatic nerve here is lying, in this case, between the gluteus maximus and the quadratus femoris muscle in an intermuscular tunnel. You can see these hyperechogenic lines, which are actually the epimysium of the muscle. So that is the perineural space through which the nerves traverse from the pelvis to the popliteal fossa, if you may. This structure can also be visualized today with biplanar imaging. This is a real-time biplanar imaging where you can see the sciatic nerve in both the transverse and the sagittal view simultaneously, and with refresh rates that are often conducive for intervention. That means the frame rates are high enough that you can perform needle guidance. These are matrix transducer of some very expensive technology, but I think they are getting more and more affordable in the near future. As you can see here in the sagittal view that the sciatic nerve actually is surrounded by a hypoechoic area. This is that perineural space. So the perineural space, ladies and gentlemen, is actually an intramuscular tunnel. This is the tunnel through which the nerves travel from their origin to the point where they divide and supply the nerves or the skin, etc. It is also the conduit into which you inject your local anesthetic, and the local anesthetic can spread proximally and distally. And this is not something that I have just thought up or most researchers have thought up. Actually, it's looking straight on your face. You can see, if you look at an MRI of the thigh, you can see there's a big intramuscular tunnel through which the sciatic nerve with the neurovascular structures traverse from the proximal part to the distal part. Now, I present to you that this intermuscular tunnel is packed with a lot of connective tissue. As you can see, this hyperdense, bright structure that you can see here is indeed the adipose tissue that is surrounding the sciatic nerve. Now, most local anesthetics are very lipophilic. So the more lipophilic the drug is, more of it will be absorbed into the fat before even it gets to the nerve. Makes sense, right? So therefore, you see that many times when you do these major nerve blocks like the sciatic nerve block, you have to use a large dose, a large mass of the local anesthetic. So this is that perineural space into which you inject your drug and through which the effects of the block occur. Is this only true for the sciatic nerve? No, ladies and gentlemen. If you look here, there is the interscalene groove where you can see the brachial plexus elements that you see here between the scalenus anterior and the medius. Here you can see the costoclavicular space. You can see the adductor canal. This is the subgluteal space. In all these locations, the nerves are actually traversing through this perineural space. This space is laden with adipose tissue. It can also be visualized in the sagittal view. This space is not only filled with fat, there are vascular structures, veins, arteries, lymphatics. So all these do matter when it comes to your performing the block, either for the good or for the bad. Another structure that has become quite relevant in recent times is the connective tissue layers that surround the sciatic nerve. Now, many years ago, the surgeons used to call this the mesoneurium. So you have an epineurium, and they said the mesoneurium is a structure that actually surrounds the sciatic nerve on the outside. Unfortunately, this is Dr. Jerry Vloka and Admir Hazik. They did some exceptional good work in relation to regional anesthesia, but one of the confusions that Jerry actually left with the with the sciatic nerve was to define this structure as the common epineural sheath. Because at that stage, they really found that this is a connective tissue layer that is outside to the sciatic nerve. And without having a proper terminology at the time, they called it the common epineural sheath. So unfortunately, this led to a host of different terms being described, given that there was some confusion as to what this structure really is. You can see here, the same authors have actually described it as with a different name a few years later, a common epineural sheath, and then Bloch again describes it as the popliteal nerve sheath, and today it is called the perineural sheath. And as a result, a host of different injections and terminologies have been described, starting from perineural injection to intraepineural injection, subepinural, subfascial, etc. So there led to a host of confusion as to what all this is all about. I think I draw your attention to this wonderful article by Dr. Carlo Franco. It was an editorial following Dr. Anderson's work from Scandinavia, where he said, if you imagine the epineurium, which is the outer epineurium of the nerve, as the skin of the nerve, then anything inside that skin is an intraneural injection. Anything outside that skin of the nerve is an extraneural or a perineural injection. The perineural sheath was described by this group researchers from Scandinavia. They showed that the perineural sheath is indeed macroscopically and microscopically different from the epineurium or the skin of the nerve, and an injection which is outside or inside. This is an outside injection, this is an inside injection. Outside or inside this sheath produces different pattern of spread, so much so that an injection outside is quite localized, whereas an injection that is deep to this perineural sheath will spread many centimeters proximally and distally. And as you can see here, this dissection also will show that it doesn't stain the inside of the nerve, as you can see here. So this is not an intraneural injection. It is an extraneural injection, but it is a subfascial that's below the perineural sheath. Using high definition ultrasound, we have also demonstrated that this structure can be visualized. As you can see here, the perineural sheath and the posterior aspect of the sciatic nerve can be visualized in the posterior part of the nerve that you see over there. Next is, so this structure is actually very closely opposed to the nerve. So sometimes it's not very easily definable, and it depends on the resolution of the ultrasound machine. But it is a connective tissue layer that can be very clearly defined, as you see here. It's a very thin connective tissue layer that encompasses the nerve. So, ladies and gentlemen, you would agree if I said that the anatomy of the nerve or the anatomy of the site is more complex than what the literature suggests. I submit that we should be looking at the nerve in entirety, where you're looking not only at the nerve, but also the connective tissue layers that surround the nerve. Like, for instance, the green structure here is the perineural sheath. The white tunnel that you see outside is the epimysium of the surrounding muscle that creates that perineural intermuscular tunnel. And there's adipose tissue in that intermuscular tunnel. So where you inject your local anesthetic may influence the dynamics of the block. So you have essentially two compartments, one that is outside and the one that is inside this perineural sheath. So this is still a perineural injection. It is not an intraneural injection, as some have described in the literature. So subfascial injections, being closer to the nerve, would, or maybe they are, produce onsets and efficacy of the block that are different from an extrafascial injection, and I will come to that in a moment. So when you perform an injection today, it is conceivable that you will be able to perform the injection either outside or inside this. And as you can see in this cadaver dissection, a subfascial injection, you can see, produces extensive craniocaudal spread. This is only the sciatic nerve specimen, but you can see it's been stained not only on the sciatic nerve, but also as the sural nerve emerges from the common peroneal nerve on the image to your right and to the left. You can see there's extensive craniocaudal spread. Using high-definition ultrasound after the injection, this sheath becomes much better visualized. You can see that the perineural sheath is actually like my trousers, if you may. If I inject on the proximal part of my trunk, it divides into a part that surrounds the common peroneal and the tibial nerve. The common peroneal is the nerve to your left in each of those images, and the tibial nerve, being larger than the common peroneal nerve, is to your right. You can see they are individual connective tissue layers that separate out once you perform the injection. And this is again illustrated here so the perineural sheath is septated inside to surround the individual nerves. So when you inject, it produces this typical twin halo site. Now, you may not have a very high definition ultrasound machine, but if you perform an injection at the bifurcation of the sciatic nerve and you perform a dynamic scan, that means you scan proximally and distally as you inject your saline. Once you see this twin halo sign, you know that your needle is subfascial. Make sense? Okay? So look out for this subfascial spread in this twin halo sign. You can also see this trihalo sign. The twin halo was actually described by my good friend Dr. Xavier Salablanche from Barcelona. So I also found that you can see the trihalo sign. This illustrates that this perineural sheath is an integral part of the nerve. And as the nerve goes further, it follows the nerve with its branches and divisions. So the perineural compartment has become a new destination. And as I mentioned, it's being an integral part of the nerve, you can perform an injection deep to it or outside it, as Dr. Massey from the United States demonstrated. So when you perform an injection that is outside, which is the image on the bottom pane, and the image that is on the upper pane is the one that is subfascial, you can see that there is more circumferential spread, there's more craniocaudal spread, in contrast to the extrafascial injection, which is got quite a limited spread, limited to only a small segment of the nerve, as illustrated in this freehand three-dimensional imaging. Clinically, there is a greater longitudinal spread, and the complete onset of sensory blockade is much faster in the subfascial as opposed to the extrafascial group. Other researchers have also demonstrated that subparaneural injections produces significantly and consistently shorter onset times of sensory motor blockade. So the next question is, if this structure is so closely opposed to the nerve, what is the optimal technique? Should we be doing it above the bifurcation? Should we be doing it below the bifurcation? So those of you who follow the literature, you'll say, oh no, here we go again. We start the whole story all over again like we did when we did nerve stimulation. So much so that an injection below the bifurcation was shown to be better when you inject the individual common peroneal tibial nerve. So to start this whole journey, we said, okay, let's try and do this subfascial injection, because today there is no data to say where you should be performing the injection, although most of us perform it at the bifurcation. So we said, let's start off first with above the bifurcation, where the nerve is before the nerves divide into its common peroneal tibial nerve. As you can see, I usually perform it in the prone position. We use, this was a research project, we use multimodal monitoring with ultrasound, nerve stimulation, and even injection pressure monitors were used because we go very close to the nerve. And the needle was introduced from a lateral to medial, that is from the common peroneal side, as you see in this illustration, that the needle is being introduced from the lateral side and onto the lateral edge of the nerve. And as in the subsequent images you can see, as you hydrodissect your way, there will come a time when you're either outside or inside. But once you enter the inside of the subfascial layer, you will see that connective tissue layer pops up. Now, because we are approaching the nerve very, very close, I advise you to introduce the needle at the lateral edge of the nerve, because this sheath is quite redundant laterally. So once your tip enters the lateral aspect, now this is an extrafascial injection. It's pushing the nerve away. Okay? And if you do a dynamic scan, you will see that this saline is very localized to close to the point of injection. In contrast, once you enter this subfascial layer, You can see here, this connective tissue layer now pops out. You can see, now the nerve becomes a different shape. These are telltale signs that now you have entered the subfascial compartment. And if you perform an injection in this area, you should be able to, yep, that's it. You can see now, as I inject the local anesthetic, it's spreading around the nerve, and so much so that you can not only define the perineural sheath, but the local anesthetic. Some of the local anesthetic also diffuses out because it's a very semi-permeable membrane, or it's a very thin membrane which probably leaks out, as Dr. Anderson also shows that when you perform injection, this structure actually forms many blebs. So with high definition, again, I submit to you that you can see the structure very clearly, and the spread of the local anesthetic around it is not only seen in the transverse, but also in the sagittal view using multiplanar imaging, 3-dimensional, and you can see transverse view, the sagittal view, and the coronal view, and you can see the connective tissue layers very clearly. Even if you do volumetric imaging, you can see how the local anesthetic actually surrounds the anterior, posterior, upper, front, back surfaces of the nerve. So now this is really wonderful because the drug is deposited very quick, very close, and it has a wonderful spread, almost encompassing the entire cross-section of the nerve, and it exposes the nerve to a long distance where the local anesthetic is affected. Well, what kind of a block does it produce? If you look at sensory motor blockade, you will find that this is the profile of the 4 divisions of the sciatic nerve: the superficial peroneal, deep peroneal, sural, and tibial. You can see that the tibial nerve dynamics are different, which is the green, from the common peroneal component. So this also illustrates, again, the tibial nerve is more resistant to block because it is a larger nerve. But when we looked at the incidence of complete sensory and complete motor blockade, the complete sensory is the black bars, the complete motor block is the red bars at 30 minutes. See, it's pathetically poor, 40%. So at 30 minutes, if you want to do surgery on these patients, maybe the patients are not ready enough, they're not ready for surgery. How does this differ from when we didn't do subparaneural injections? If you review the literature by this group, you can see that the complete sensory and complete motor blockade are no different than when we use ultrasound with nerve stimulation. But then you may be wondering that about 14 centimeters of the nerve has been exposed to the drug. 80% of the nerve has been surrounded by the local anesthetic. It produces still very poor onset of block, but the duration is very prolonged because you put a large mass of drug near the nerve, so the efflux of washout is obviously going to be slow, and this has been shown with umpteen number of other studies. So this is a radar plot that radar weatherman usually uses. So we adapted this, and you can see if you plot these in this way, you can see that the spread of the drug is more along the common peroneal than on the tibial side, and therefore you have seen that the common peroneal side onset is faster. So it begs the question that should we be doing a multiple injection above and below, or should we be doing the injection above or below the bifurcation? So now you can see that even with a subparaneural injection, which many of you may think it is the holy grail of sciatic nerve block, not really, ladies and gentlemen. So it actually brings more questions than answers. But because we are going very close to the nerve, we also found it produces very high incidence of paresthesia. Fortunately, these paresthesia didn't translate into neurological sequelae, but paresthesia may not be a good thing because it often induces inflammation of the nerves, as shown by Dr. Steinfeld from Germany in animal models. We also use this stacked model. So those of you who are familiar with transesophageal echocardiography will be aware of this, because this is the same technique that is often used to measure ventricular volumes, atrial volumes, and so on and so forth. So we took a volume of the sciatic nerve, 3 volumes, at the point of injection, above and below the point of injection, and we then mapped out, it's like a loaf of bread, if you may, and you slice it up into many pieces, and then you map the area of the sciatic nerve and the area of the spread. So the purple or the pink is the nerve, and the outer with the blue is the local anesthetic in the volumes that you see. So when we stitch them up together, this is the composite view of the spread of the local anesthetic after a single injection above the bifurcation of 25 mils of local anesthetic. You can see how the sciatic nerve is surrounded by this local anesthetic. It divides into common peroneal and the tibial nerve. But even with this, and even with such an extensive spread of the local anesthetic, we find that the block is not really as good as we normally envision it would be. So as I mentioned, that there are actually more questions than answers that come out from this work. So what is the ideal site of injection? We don't know. Do you need a circumferential spread because you're so close to the nerve? What is the choice of local anesthetic? Will it matter? Because now when I use ropivacaine, it produces 19 hours of blockade. And in fact, one of my cases, without an intraneural injection, it lasted for 37 hours. It's quite worrying sometimes. But because we are so objective and we've seen these blocks in our ultrasound images, we know these are not intraneural injection. So sometimes when you deposit a large dose of drug very close to the nerve, it's understandable why this may lead to very prolonged duration of block. And having a leg that is paralyzed for 37 hours in the worst scenario is not a good thing. So would lidocaine be a good agent? Maybe. We often say lidocaine is a very short onset, quick offset. But I think this begs the question, maybe we should be rethinking this philosophy because we are going very close to the nerve. So the dynamics of these nerves are being evaluated and an ongoing study at our institution looking at lidocaine versus ropivacaine. Maybe when we meet again next time, in a few years' time, I will have some of these answers. So we've compared dynamics between single and double injection, subparaneural, and this was done. And so those of you who want to do this, best to put the needle at the bifurcation, hydrodissect this plane, and then you will see the local anesthetic spread above and below the bifurcation. Then we put a needle either above or below as one injection, or then you perform the injection, or you place the injection above and below, like this is a injection, 2 injection above and below. Not surprising. This is the dual injection technique. Dual injection technique produces faster onset of sensory and the overall motor blockade, and the percentage of complete sensory motor blockade is much faster in the group that you perform. This is 40 minutes, and you see it's much faster in the dual injection group. Okay, I have a few minutes, so I just want to put the same concept into the brachial plexus. The brachial plexus sheath, does it exist? Actually, there is a lot of controversy, some saying that it's a fact or is it a fiction. Dr. Franco has demonstrated that this structure actually macroscopically exists. Dr. Shiva Shanmugam has shown that you can perform extrafascial and subfascial injection. Extrafascial and subfascial injection produce different patterns of sonographic spread within the nerve structures. They also produce, subfascial injection produce faster onset of readiness for surgery and a prolonged duration of, and a longer duration of sensory motor blockade. This is a picture from the Philippines many years ago when I was looking out through this to the sea in Boracay. I said, oh, but then it's very difficult to visualize the sheath. But then you can use hydrodissection, as I illustrated to some of you in the master class. So this is the supraclavicular fossa. Where is the sheath? There are many connective tissue layers that are surrounding this. So you can use hydrodistension. You can use normal saline. As you can see, I've introduced the needle, and I'm going to inject a small aliquot, about 1 or 2 cc's. You can see it's pushing the sheath away. It becomes more clear. Unfortunately, this is the king of the road that has disappeared from our roads here in India. So now if you can see that the sheath is now being pushed away, and you can then find a sweet spot through which you can insert the needle. As my good friend Andre Bozat said, for every nerve block there is a sweet spot. So you hydrodissect this area, you will see the sheath, and then through that you can find a sweet spot through which you can insert the needle, and thereby you will be able to produce, a good subfascial injection. You can see here, this is almost within the cluster of nerves, but it is subfascial, and this produces very rapid onset sensory motor blockade. The last few slides is to just illustrate to you that this structure actually exists, and we've demonstrated in post-injection images that this brachial plexus sheath exists not only in the costoclavicular space, it also exists in the medial infraclavicular space. It also exists in the lateral sagittal infraclavicular space. You can see the structure is actually septated by this compartment, anterior and a posterior compartment. The anterior compartment usually encloses the lateral cord. The posterior compartment includes the medial cord and the posterior cord. And you can see here this anterior compartment with the septation that you see here. And this is the cartoon that would show you. Now, what would be an intraneural injection? An injection that is deep to the skin of the nerve. It can either be extrafascicular or intrafascicular. Intrafascicular injections are a no-no. I think they are also very difficult to perform, but if you try hard enough and you persevere, I'm sure you can. Also in areas that are laden with more nerves than connective tissue, like in the ventral rami of the brachial plexus in the interscalene groove, because there's a lot of neural tissue. If you inject, you can have quite devastating consequences. But in the sciatic nerve, in the popliteal fossa, you will find, with the last slide here, is that if you perform an extrafascicular injection, there may be no clinical or electrophysiological changes of nerve injury. Now this is really at odds to our understanding and beliefs. So, an intrafascicular injection is bad. That's the ugly part of nerve blockade, which you don't want to do. But sometimes an extrafascicular injection may occur. I don't recommend you continue the injection, but if you avert further injection, no harm may come to the patient. So with these few words, ladies and gentlemen, I'd like to conclude by saying that I think we should start thinking of peripheral nerve block with the entirety of the structures that surround it, and and I hope I have illustrated to you that where you perform the injection can influence neural blockade. While we initially thought that the subparaneural compartment would be the holy grail for sciatic nerve block, but today emerging research says that no, we need to still understand more about peripheral nerve blocks before we can really come to a stage when peripheral nerve block will become like general anesthesia, as Harold mentioned yesterday. Until that day, it will never be popular. So I have a dream, as I'm not Martin Luther King, but I too have a dream. May not be in my lifetime, but I think there will come a day when we'll be able to do peripheral nerve blocks like general anesthesia, which is consistent, repeatable, and which works on Monday as well as on a Sunday. Thank you, ladies and gentlemen.